Good morning. My name is Megan Kroll. I am a rising second year. I'm not saying that quite yet. Here at Mercer, and I am happy to introduce Dr. L. Joy Baker, who is a board-certified general OBGYN in LaGrange, Georgia. She has worked in both urban and rural communities for over 10 years. After completing her medical school and residency training with honors at the Morehouse School of Medicine and Grady Health System, she currently serves as Director for Quality and Safety for Women's Health at Wellstar West Georgia Medical Center, where she also serves as Department Chair of OBGYN and Pediatrics. She is one of the first physicians in the U.S. to complete an HRSA Fellowship in Transformational Healthcare Leadership at the Morehouse School of Medicine, and successfully completed the Medical Association of Georgia's prestigious Physician Leadership Academy, earning recognition as Georgia Trend's top doc in the OBGYN division. In 2019, Dr. Baker was one of the first OBGYN physicians in the U.S. to earn special certification in perinatal mood and anxiety disorder, as well as treatment of addiction and pregnancy. Her clinical and research interests currently include health equity for Black and Brown women, particularly with regard to maternal morbidity and mortality, statewide perinatal quality improvement, and minimally invasive GYN surgery. She speaks these topics locally, regionally, and nationally. In response to the COVID-19 pandemic, Dr. Baker's passion for educating and empowering the public prompted her to launch Delivery Joy MD on social media platforms to connect virtually with her patients and others to provide reliable women's health information. Dr. Baker is a Georgia native born in LaGrange to a family with a long history of service in the LaGrange and surrounding communities. She is a proud member of Alpha Kappa Alpha sorority and the Lynx. She worships and serves at Impact United Methodist Church, where she is certified lay minister. Dr. Baker enjoys roller skating, music, books, shopping for discounts, and interior design. Thank you for being here, and please help me welcome Dr. Baker.
Good morning. Good morning. How is everybody? I have a mic here just in case I start wandering around, because I'm known to start wandering around and talking. So I'll use that if I get the desire to move. So I guess I'm going to hit next slide. Got it. All right, so today we are talking about preconception health. We're talking about preparing for success. And I don't have any financial disclosures, and I say this at every talk I give. If you would like to give me money, I'll be happy to disclose it. So this morning, we're going to try to meet these objectives. We're going to talk about reproductive intentionality and preconception health and how these interventions can improve maternal health outcomes. We're going to provide a holistic framework that clinicians can choose to use when helping patients prepare for pregnancy, and a template for assisting our patients and clients in thinking through their reproductive life plan, which is very important. So this is something that's really kind of near and dear to my heart. And I wanted to share a story with you guys before we get started. This young lady here is Lois. This is Lois. This is my grandmother, Lois Hatchett Baker. And this is where I learned about reproductive life planning. I learned from her. She was a phenomenal woman. So Lois was at Fort Valley State in the 1940s, the late 1940s. And in 1949, she was named Miss Fort Valley State. And so she's walking around. She just learned that she was going to be the queen of the university, and she was planning her coronation. And by her goes this gentleman on a horse. And he had just returned from World War II, and was one of the few Black soldiers that actually was able to get the GI Bill. And so he was at Fort Valley State. And he had a horse because he couldn't afford a car. So she saw this horse, and she got this idea that he was going to drive a horse-driven carriage for her coronation with her in the back, waving at everybody. And she told him, she said, "I hear that you have a young lady you've been seeing on campus. You need to tell her it's over because you just met your wife." And that's what she did. And you see it worked, because this is them and their family here. So the interesting thing about my grandmother Lois is that she really had this philosophy about making sure that you get out of your life what it is that you want out of your life. So she was a very empowered, forward-thinking woman back in the 1940s and 50s. And so they got married in 1950 when they graduated from Fort Valley State. And my grandmother sat down with my grandfather and they made this master plan. She said, I'm going to plan to have 3 children, 1, 2, 3. They're going to be 5 years apart exactly, so that none of them is in college at the same time because we're going to pay for their college education so that they don't have any debt, right? So they're exactly 5 years apart. My dad, George, my aunt, LaPearl, and the little one here is Jamae. And so she was very successful in doing that. And, you know, we think about today where 50% of pregnancies are unplanned or unintended. And we have so many more options now to prevent pregnancy than we did back in the 1950s, right? So it was very interesting to me how she set this up. She was a librarian, and my grandfather taught auto mechanics and mathematics. So she brought a book on conception and fertility, and she learned to check her temperature, watch her cervical mucus, count out her days of when she might be fertile, and she did that for all of her kids. So I think preconception health is something that we really need to start thinking about and getting back to, and the reproductive life plan is something that can really benefit us in terms of our outcomes. And so setting intentions can help us improve outcomes, and I think probably I'm talking to the choir in this group because most of us know the newest CDC data on maternal morbidity and mortality, particularly maternal deaths in Georgia. And so we know that the US is the worst developed country in which to become pregnant or to birth, right? But we also know Georgia is one of the worst states in which to become pregnant or to birth. So when we're in last place, we're not just in last place in the US, we're actually in last place in the developed world. Wow. So we have to let that sink in. And so in Georgia, women are twice as likely to die than our national average. And so we want to see how we can combat that. And when we think about the disparities that are taking place, I mean, I think we all are appalled by them. But we can see that Black women are almost 2 times more likely to die than white mothers in the state. And when we also think about the fact that Black mothers make up 30% of all the maternal deaths, yet they make up less than 10% of the national population, that lets us know that we have a lot of work to do in terms of closing these health disparity gaps. So when I was thinking about this talk, I said, well, what should we be talking about here? And I think that it's always important to lead with data. So this was a Cochrane review, and a Cochrane review usually looks at a bunch of studies and kind of does a systematic review and meta-analysis. And so this was 36 studies over 22 years that looked at maternal and infant outcomes in intended pregnancies versus unintended pregnancies. And we were able to see statistically significant improvements in those people who had intended pregnancies. And so some of the outcomes that they were looking at included depression in pregnancy. And I thought this was pretty amazing. So look at the difference in the depression rates during the pregnancy. There's a 10% difference there. So that's definitely statistically significant. And then we saw increases in postpartum depression for unintended pregnancies and interpersonal violence. And we know during pregnancy, whenever folks are dealing with interpersonal violence, that's when it can get really bad. That's when there is a higher risk of actually, that person being murdered by their abuser. So really interesting to look at that and to think about how just being intentional about the reproductive life plan can help us improve those numbers. And then we saw increases in preterm birth and low birth weight with unintended pregnancy. So the goal of preconception care is really to have an opportunity to identify risks that mom might have that might cause her to have some adverse pregnancy outcomes, and to educate that person on what the risks are and what kind of options we have for interventions to reduce those risks, and what alternatives are there, what's out there. And once we've had an opportunity to have that discussion, then we can use our shared decision making to talk about what interventions we want to actually implement to help improve those outcomes. And that could be things like motivational counseling, disease optimization, maybe getting those chronic health diseases under control, and certainly getting them to see other specialists if there are other medical problems that are happening that we want to work up or to get more information about. And so the framework that I like to work from in my clinical practice is the holistic preconception health. And this is usually split up over about 2 to 3 visits, about 30 minutes apiece. So you gotta have time to do this, right? So if you're a busy clinician and you're seeing 30, 40 patients a day, this model probably won't work for you. But if you have time to book people at least 30-minute slots and usually about 2 to 3 visits, we can go through all of this. And so we're talking about an opportunity to just pause and consider your holistic wellness. Consider your patient or client's holistic wellness. And so physical, mental, emotional, spiritual, financial, relational, and social issues all come into play here when you're talking about becoming a parent and surviving a pregnancy. So let's just kind of delve into this a little bit. So with physical health, I will spend the bulk of the time talking about this because we know that there are lots of complications that can come up that contribute to maternal morbidity and even poor infant outcomes. But preconception health checkup in the office for me is an opportunity for that first visit for us to just kind of sit down, get to know each other. I start asking questions about the family. I want to know about the genetic history because we all know something might have been wrong with Uncle Bobo, but we don't know what it was, right? Because we don't talk about that stuff, particularly in the South, And so, Uncle Junebug had something going on. We don't know if it was Down syndrome or autism or what. We just knew it was different. So we need to talk about that, and we need to encourage our patients and clients to ask those kind of questions so that we know what things we should be screening for, what things we might be expecting. Personal medical history is certainly important, and I don't know, how many clinicians do we have in the room? How many people are dealing with patients or clients every day? Okay, good. So you know what it's like when someone comes in and says, oh, I've been healthy all my life. And then you get to asking a few more questions a few different ways, and you find out, oh, actually, I was in the hospital for 2 months after my stroke, and, so you have to ask a lot of questions. So I ask a variety of questions like, any medical problems like asthma, diabetes, hypertension? Oh, no? Okay, have you ever been in the hospital before? Oh, yeah. Yeah, they had me on a breathing tube because I had pneumonia and my lung collapsed. I was like, oh, okay. There are lots of these little details that we often miss when we're not taking the time to sit down and talk about these things. Surgical history is very important. I had a patient actually when I was in residency at Grady she was from Macon. She had spina bifida, and she had a problem where her bladder, the size of her bladder was very small. So they did what's called an ileoconduit, which means they took a loop of her intestines, pulled it down, and helped create a bigger bladder for her. But the bladder sits where? Right in front of the uterus, right? So she's pregnant, and we're like, oh, wow. And we don't know if, because of some of her spinal deformities, if she's going to be able to have a vaginal delivery. So now we're like, what if she needs a C-section? Her whole bowel or intestine is pulled down over the uterus. And we're like, oh, snap, what are we going to do? So thankfully, she delivered vaginally. But, that surgical history can be very, very important. We need to know about that so that we can kind of coach and guide patients and have a really comprehensive plan for how we're going to help manage their pregnancy and delivery route. GYN history, so we know when do they start their periods? Are they having regular periods? Is this someone who we think is going to have some difficulty achieving a pregnancy when they decide to get pregnant? And certainly sexual history is very important. And not only because we're looking for history of infection that might kind of block us from getting pregnant, because sometimes we see patients who have had sexually transmitted infections like gonorrhea, chlamydia, and may have scarring on the fallopian tubes. So it's very, very important for us to kind of know that sexual history, but also so that we can, kind of coach and guide our patients to when is the appropriate time for timed intercourse when it comes to getting pregnant. So we got to kind of pay attention to that. And certainly if they've had babies before, asking questions about their pregnancy history. What happened at your birth? And a lot of times people say, oh, my birth went great, it was wonderful. And I'm like, oh, okay. Did you have like a lot of bleeding, or did you have to, have any interventions? Oh yeah, I did get 2 units of blood after I delivered. So you really have to ask these questions. You can't expect people to sort of volunteer this information. And so lab studies come next. So usually at that first visit, we have a really detailed talk about their history, and I'll get labs. So labs can include the complete blood count. We have a comprehensive metabolic screen, and I'm looking at Dr. Callens in the back here, and I'm remembering one time at Grady, because if you don't know, Dr. Callens was my chief when I was a resident. And we trained together. And so there was this lady, young lady, she looked perfectly healthy. She came in, I can't even remember why she came in, but her blood pressure was like 200s over 100. Do you remember her, Dr. Collins? And I was like so worried about, okay, we're gonna treat the blood pressure and treat whatever it was. And Dr. Collins was like, let's get a comprehensive metabolic screen. And it turned out this lady had kidney disease, like pretty bad kidney disease. So we were like, oh, okay. So she had some secondary causes of her hypertension. So it's important to really look at that. Our A1C and glucose to check for diabetes. And then the hemoglobin electrophoresis is a test that looks at how we're making our blood cells, what sort of chains are combining to form our blood cells, and if we have things like sickle cell disease or thalassemia. And then rubella, varicella, hepatitis B and C, our HIV and syphilis, and then of course our sexually transmitted infection panels. And if you have patients who are over 21 and they are not up to date on their pap smear, this is an opportunity to screen for cervical cancer. Cervical cancer in pregnancy is actually bad news. So we know that folks who have cervical cancer who undergo pregnancy are much more likely to increase the stage of cervical cancer by the end of pregnancy, and those women might also benefit from a cesarean delivery. And so if we have an opportunity to screen, we should do that. And then, of course, your genetic carrier screening. So you can screen for cystic fibrosis, spinal muscular atrophy, and Fragile X, and, of course, others. So if you ever find out what Uncle Bobo had, there are tests for that you can screen for to see if that parent is a carrier. And so some special labs that we sometimes look at is for thyroid studies, folks who have history of disease, or you see a big old goiter or swelling on their throat, or if they're reporting symptoms that might be related to their thyroid. And then lead levels for people who live in buildings or work in buildings or spend a lot of time in buildings that were built before the 1970s. That's something that we might want to check out as well. And if they are recently immigrated to this country or have had a long-term travel history, there are lots of other things out there that can get us and that can cause some significant problems in pregnancy, like Chagas disease, tuberculosis, and Zika. So my favorite thing is specialist consultations. So when I have someone that I think may be extremely high risk, I like to call all my friends and share with them. I like to share these patients with them because we want to make sure that these patients are adequately taken care of. So my favorite one is the cardiologist these days, because we've seen the data for Georgia. Our Department of Public Health has been extracting these cases when moms have severe morbidity or when they even have a mortality. And we know that cardiovascular disease is the #1 killer of Georgia moms. So it's important for us to pay close attention to cardiac warning signs and cardiac risk factors in our pregnant population. And if we have the opportunity to do it before they're pregnant, even better. So I like to talk to my patients about any history of preeclampsia, any history of cardiomyopathy or peripartum cardiomyopathy, or if they have any other congenital or acquired heart disease. It's very important for them to see the cardiologist prior to becoming pregnant. We know that preeclampsia is actually probably a sign of underlying heart disease. So those women are at significant risk for developing heart disease fairly early in life. Chronic hypertension is another one. Those folks definitely could benefit from an EKG and a workup before becoming pregnant. If they have diabetes or a body mass index greater than 50, or if it's greater than 40 with other comorbidities. Very important to have that checked out. Pregnancy puts an extreme demand on the heart and the cardiovascular system. So your heart, when you're pregnant, is working 2 to 3 times the rate that it works when you're not pregnant. So it's really important that we are screening for these folks. And of course, people like me who are old, the advanced maternal age people who are over 35, we definitely want to make sure our pumper is pumping before we try and get pregnant. And then pulmonology, we see quite a few patients who have reactive airway disease or asthma, and having those pulmonary function tests are important because one of the physiologic changes in pregnancy is that our respiratory reserve decreases, and we sort of hyperventilate a little bit. So if you're someone who can't push out air, that's going to be really difficult for you. So very important to have that pulmonology consult. If you have people with uncontrolled diabetes or thyroid disorder, endocrinology can be helpful. And for any of my patients who have any comorbidities, I like for them to just have an opportunity to consult with the maternal fetal medicine specialist so that we can kind of make a plan for how we're going to do this in pregnancy, how we're going to manage their medications, how we're going to make sure that they're getting the appropriate care. And autoimmune disorders go to the rheumatologist, and then my friends in neurology handle folks with epilepsy or chronic uncontrolled migraines. And then I'd like to dwell a little bit on nutrition because nutrition is very important. If I have a patient who is underweight with a BMI of less than 18 or a patient who's overweight with a BMI greater than 25, I want them to see a nutritionist so that we can get some ideas for how to get them to a healthier weight range. And then also, if they admit to having a poor diet, I love my staff, but I will tell you, there are 2 people on my staff who do not eat a single fruit or vegetable ever. So even if I cook and bring the stuff to the office, they're like, oh, it's green. I'm not going to eat it. So some people, we have a subset of people who really just literally eat meat and bread and carbs. So we need to talk about that because a poor diet can be very, very devastating, not only to the overall health of that person, but when we're talking about pregnancy, there are so many vital nutrients that we need to be able to distribute. So those folks may really benefit from a nutrition consult to find out what things they like, what things they don't like, what can we substitute for some of the things that they're eating, what new foods can we get them to try. And then if they've had bariatric surgery, we want to definitely make sure that they're able to see a nutritionist and be followed so that we're putting together the right nutrients for them because they may not be absorbing the nutrients from food. And then our diabetics, of course, can use some diabetic teaching. And that leads me to diet and exercise, no matter your size. Now, you do not have to be a size 2 to have a healthy pregnancy, but you do have to be taking good care of yourself. I always talk to my patients about treating themselves gently, making sure that you're eating well, that you're exercising, that you're getting enough sleep. And so there are lots of essential nutrients that are needed in pregnancy, like folic acid, iron, calcium, magnesium, potassium. I like to have prenatal vitamins, and then I may even throw in additional supplements, and I am in love with probiotics. I think probiotics are just so good. We need good gut health. And it's important to also maintain our vaginal health. So it really helps. And since I've been using probiotics, I've seen a real decrease in my patients anecdotally with group B strep, believe it or not. So I hardly ever have group B strep now since everybody's on a probiotic. Anyway, so if we have a need to lose or gain some weight, that's an opportunity for us to do that, and our nutritionist can be very helpful with that. And for cardiovascular fitness, the American Heart Association recommends 150 minutes per week just for general well-being, but if you're trying to prevent weight gain, 150 to 250 minutes per week, and if you're trying to prevent weight regain, you need even more. I thought that was very cruel because it's like after I've worked hard to lose all this weight, you tell me I have to increase my activity to keep from gaining it back. So so definitely diet and exercise is super important. And optimizing chronic health conditions. So hypertension is probably the most prevalent condition that we see for folks who are planning to become pregnant or who are pregnant. And so in pregnancy, we really want that blood pressure to stay below 140/90. We used to say 150/100, but we actually realized that it's much safer if we keep the blood pressures lower, and it does not increase adverse fetal outcomes. And so safe meds in pregnancy can include beta blockers, calcium channel blockers, the good old Aldomet that's been around since probably 100 years, and then hydralazine. And in diabetes patients, we need really tight sugar control. And so in case you didn't know, I don't know how excited you were when you learned about this, but I was very, very excited. Continuous glucose monitoring has been approved in pregnancy. Can I just get a hand for that? Yes. Okay, I'm being overly dramatic, but For the longest time, patients would have to prick their finger in the morning and 2 hours after each meal and write it down, and they would bring you their blood-stained report to the office every week. And it was very difficult for them. It was difficult for us to keep track of it. Most folks didn't want to do it. You get people bringing you logs. Like 2 weeks ago, someone brought me a log where all the numbers were in the 60s, and I was very suspicious. So we outfitted her with a continuous glucose monitor, and now I can pull it up from wherever I am and see what her blood sugars are running. And they were not in the 60s. So this is very important. And so you can even use this for folks who are planning for pregnancy if they have diabetes or insulin resistance, to really start watching those sugars and help them get those sugars well controlled before conception, because we know that diabetes really increases the risk for stillbirth, it increases the risk for miscarriage, and for fetal anomalies, especially heart anomalies and spine anomalies. So diabetes control is very, very important. And you can use some of the oral medications like metformin and glyburide safely in pregnancy, but insulin is probably still the tried and true. You get some better results with that. And then getting the thyroid disease under control, getting that T3 and T4 normal. We used to always think about you have to keep the TSH below 2.5, but now we know it's really about normalizing the T3 and T4. And then, of course, there is the elephant in the room. Our obesity rates are skyrocketing. So 1 out of 3 women of childbearing age, or people with the capacity to become pregnant, I'm saying women a lot, but I have all people included who can have a baby. But 1/3 of US women are actually dealing with obesity. And there are a lot of factors that play into that. It's not necessarily that they are to blame for that, but we do need to start paying attention, because we know that when someone who has a BMI that's greater than 30, it's been linked to a variety of adverse outcomes for moms and babies, including gestational diabetes, hypertension, preeclampsia, increased C-section rate. So once the BMI gets up to 50, the C-section rate is about 50%. So that's huge, right? And we know that C-section is a huge predictor of severe maternal morbidity. And every time we have higher severe maternal morbidity, we are just waiting for a mortality. So we have to be thoughtful about how we're doing that. And then we can have larger babies, preterm deliveries, and even sometimes stillbirth. So discontinuing harmful substances is something I talk about a lot in my clinic, because we see a lot of patients who have substance use disorders. So, usually it's not that people get pregnant and become substance users, it's that people who have dependence on the substance become pregnant, and they're remaining dependent on that substance. And so we have to talk about that. And I love when I have the opportunity to do this before pregnancy, because, alcohol is probably the most prevalently used substance around the time of pregnancy and during pregnancy, and it is the #1 cause of preventable birth defects. 75% of women who report that they want to get pregnant as soon as possible have risky alcohol use behavior. So we need to be talking about this. And for a long time, it was really ambiguous. We were really kind of on the fence about it. As a medical community, you'd hear people say, oh, you can have a glass of wine or champagne after the first trimester, and we have to stop that. We have to make sure that we're messaging clearly to our patients and clients that there is no safe time, no safe amount, and no safe type of alcohol. So just because you had a beer versus, a shot of whiskey, it doesn't make a difference. And the reason why is because we don't know which babies might actually have a sensitivity to alcohol. There was a really neat study that came out that looked at twins, and these were dichorionic, diamniotic twins, meaning they had their own bag of water and their own separate placentas. Well, they're inside of one woman, right? And she was consuming alcohol. And so they looked at what happened with the babies when they were born. And you could have one twin that was completely unaffected and another twin who had a fetal alcohol spectrum disorder. So very, very interesting. And you just don't know who's genetically more susceptible to that. And so we have to be very careful about how we message to women. No safe time, no safe type, no safe amount. So the American College of OBGYNs has this group of of substance use disorder champions. So I get to go around and talk to residents about this and give grand rounds presentations on fetal alcohol spectrum disorders and opioid use disorders. And one thing that happens all the time is people inevitably raise their hand and they're like, well, but I mean, what if, hypothetically, and I'm like, no, it's never going to be okay. Doesn't, what about kombucha and whatever? If it's fermented, if it has alcohol content, no. So just remember, no safe time, no safe type, no safe amount. And so we know that about 3 million pregnancies are at risk for alcohol exposure. So very important to talk to patients about that when they're talking about becoming pregnant, like how much are you drinking? Because those first 2 weeks of pregnancy, we're forming the neurotube in the baby, and we don't know. Most times by 2 weeks, you don't know you're pregnant. We're out with a margarita with the girls, right? So we got to be thoughtful about that, and that's why intentionality can help us out. Nicotine consumption can certainly lead to some problems in pregnancy. And cannabis is one that we really weren't so sure about for a long time, but now the data is emerging and it's quite clear that there are certainly neurodevelopmental problems that can happen from cannabis use in pregnancy. You can see lower birth weight and even increased risk of preterm birth. So we want to be very, very careful about that. And folks who are smoking with nicotine, with cannabis, we can also see increased risk of sudden infant death syndrome, which is huge. And so 50% of babies that succumbed to sudden infant death syndrome live in the house with a smoker. So that's a big deal. And then certainly opioids. We get to transition a lot of moms off of opioids in our practice, so we will help people who are addicted to prescription opioids or folks who are on heroin or fentanyl, and we put them on buprenorphine or Subutex, and we titrate that up until they feel normal. Because one thing that happens a lot with substance use disorders in pregnancy is that we feel like, I don't know, I think the claws come out because we're like, how could this person do this while they're pregnant? And as I said before, it's not that they don't want to change or that they're not motivated, but it is that they are ill and they're dependent on a substance. And so we sort of switched them over to buprenorphine or Subutex, and that tends to work very well. And unfortunately, it can be difficult for folks who are trying to transition off of these medications because the relapse rate for opioid use disorders is about 80%. So most of my moms are going to stay on their Subutex for life. And the reason why this is so important, particularly for this audience and for us in Georgia, is that what happens is after delivery, sometimes moms will relapse on their drug of choice, and they are not able to handle the doses that they were taking before. And so we see a lot of accidental overdose. In fact, death by suicide and substance overdose is the #1 killer of moms in Georgia when we're talking about pregnancy-associated birth. So the pregnancy didn't cause that, but it was associated at around the time of pregnancy. So that actually is beating all of the medical complications that we're talking about. It's substance use and suicide. So important stuff to think about. And then, of course, if there are other substances or medications that are known teratogens, we should try to avoid those. So our preconception health check can also include the start of supplements and vitamins and probiotics, and I think I harped on that enough. I really like probiotics and vitamins, and honestly, some people really struggle with prenatal vitamins. Some people don't feel well taking prenatal vitamins. Prenatal vitamins are more so for the mom than they are for the baby, so keeping moms on vitamin supplements at least 6 months before conception has actually been associated with a reduced risk of miscarriage. So I always tell them, try to power through, make sure you're taking your substances, your supplements, and then folic acid supplementation is very important, particularly with moms who may have obesity. We want to keep them on before and after, continue that folic acid, even after first trimester on up until delivery. And sleep is very important. Sleep is a major factor for our overall health, but we know that insomnia is associated with heart disease, high blood pressure, insulin resistance, depression, anxiety. So we want to make sure that we're talking about that 6 to 8 hours of sleep every night. And for folks who may be dealing with sleep apnea, that's something that we also want to know. So do you snore? Do you wake yourself up at night? Are you having trouble sleeping through the night? we can ask these sorts of questions because sleep apnea is associated with so many other potential poor outcomes, including death. And so just getting someone a CPAP machine can make all the difference sometimes in their pregnancy outcome. So now that we have talked about the whole physical thing, when we come back for the second visit, we usually talk about mental and emotional health because mood disorders are the most common complication of pregnancy. 1 in 5 women will have a mood disorder during her pregnancy or in the postpartum period, and 1 in 3 African American women will experience a mood disorder in the perinatal period. So depression, anxiety, bipolar, OCD, psychosis, and psychosis is pretty rare, but if you have patients who have bipolar disorder during pregnancy, it's very important that we're all kind of paying close attention to them because they are at increased risk for developing psychosis. And so screening is huge. And so we usually complete a screening in our office, and then we sit down and kind of go over the lab work that we ordered at the last visit. And I ask them, like, where are you mentally? Because mood disorders can have some deleterious effects on pregnancy, like preterm birth, diabetes, high blood pressure disorders, and even low birth weight. And so I wanted to share with you guys this story. And this was a mom that we had this conversation, and we were talking about her depression and being treated. And so I'm going to let you guys see this video. And let's see if I can get it to play and make it big. Uh-oh, it's playing on here but not up there.
You got me, son. You got me. Right in the mouth. I'll try it again. Ooh. Mwah. Yeah. You are going way too fast.
Jarrell is a mom that I was working with who had some struggles with depression and anxiety during her pregnancy. We had a really good talk, and she just kind of opened up and just said, I'm struggling.
During the points where I was at my lowest, I think I felt that life was done. And I would just get so far into it until I felt like I couldn't escape from all of the pain. I knew at the end of the day, if I wanted to be healthy for myself and healthy for my child, then I had to take care of that.
Hey, it's so good to see you.
Same here.
So how's everything been going?
Great, absolutely great. Got a chunky little boy.
I know, I saw some pictures. You got all the little baby rolls.
All of the little baby rolls.
Oh my
And
God.
big cheeks. Love it.
Oh my goodness. So how have things been emotionally?
Emotionally, things were up and down. And so having the therapy side of it during the pregnancy and after has been a big help. Because I don't think I would be able to have a normal conversation with you about my emotions if I didn't have it. And so because I took that route and finally opened up and let my pride set aside, I was like, okay, maybe this will be good, and it's definitely showing improvements.
You said put my pride aside. Like, what do you think was stopping you in the past from going the therapy route?
For the most part, especially culturally, it's taboo in a sense, especially in a Black family. You don't want to seem like, oh, you're pathetic, but you want the help, but you don't want to look like you're, giving up on yourself, or people looking at you like, oh, she's crazy, or whatever the case may be. You think about all the outsides versus thinking about yourself first.
Right. Mm-hmm. And I think that's a big misconception about therapy is that you must be weak, or you must be crazy, or something must be wrong with you. And I think that that's been a misconception that has hurt the Black community tremendously, is that pride of, I don't need any help, like I'm strong enough, or this is my favorite, I'm just gonna pray about it. I'm just gonna pray about it. And it's like, no, we really do need to be serious about our mental health and opportunity now to do differently. So what has been the biggest benefit, would you say, about going to therapy and like beginning to take hold of your mental health?
The benefit of it has been to open my eyes and allowing me to be able to accept, okay, this is what my emotions are, this is what I'm feeling. If I feel myself going to a dark place, and I can take a second and stop and think where I am in that moment. And so it's just helping me to be present for my son and for my marriage as well, because the more that I allowed myself to stay so far and deep into those emotions, I was pulling myself away from where I needed to be. And I didn't want to do that anymore because I witnessed, some of that with my mom and my parents, and I have made a pact to myself, I am not going to repeat these same things. I do not want to cycle, so that's been my biggest thing.
Wow, that's amazing. And you said something to me that was key, because we talk a lot about, generational curses.
Yes.
Behaviors that we've seen, that we've learned,
Right.
and that we're repeating
That's
over
right.
and over again in our home lives,
Mhm.
with our children, with our families, with our, partners. And that is what we can call generational curses. And so by learning new skills, learning new ways to handle emotions and to new ways to behave and respond, that helps us tremendously. And that's really what therapy is about, right?
Had I not gotten therapy, going through those emotions, it would definitely be rough. Because I would be trying to fight my own self and tell my own self how to heal when I don't even know what to do. So, when you have somebody else there that can help you and talk to you and give you a different perspective around your own mind, you can't see yourself on the outside in. And having that is a big help.
Okay. I'm not too techie, so I'm gonna let Chris handle this. He's the man here on this. All right. And so I always found Jarrell's story very interesting, because she's a patient who, finally was able to voice that she was having a lot of trouble during her pregnancy. And I loved that she was so open and saying that, hey, this is kind of culturally taboo. This is something that we don't talk about, that we don't do. And I loved that she was willing to try something new. And so I really appreciated her sharing that story. And so pursuing treatment for mental health conditions is absolutely vital. And I really, really advocate for this being done before pregnancy, because pregnancy is a tough time, right? There's so many things going on, changes in the body, changes in your hormones, all sorts of things are happening. And so counseling and therapy is a great part of treatment. And then adding medication, if needed, is also okay. Most medications are quite safe, and it's recommended that we not take folks off their medications when they decide to become pregnant or are found to be pregnant. So keeping those medications that they're stable on, there are very few medications that we cannot use in pregnancy. So if you have folks who are needing medication therapy, we should be encouraging them to get that. And medication plus counseling is what I really like to talk to my patients about, because the medication just sort of quiets your mind enough so that you can do the work. Because there is something underlying there, right? So we need to deal with whatever trauma was there in the past, because we know that trauma lives in our tissues. In the study of epigenetics, I find absolutely fascinating, that is telling us that we not only are we passing down our good skin and our curly hair, but we're also passing down our trauma, and so we need to be mindful of that. And so intentionally developing the mindset for how we're going to treat these conditions and kind of develop our philosophy of parenting. I want to just share with you, I know you guys can probably not barely see that, but this was from the NIH, and they were talking about the study of epigenetics. And they say, on the simplest level, the concept of intergenerational trauma acknowledges that exposure to extremely adverse events impacts individuals to such a great extent that their offspring find themselves grappling with their parents' post-traumatic state. A more recent and provocative claim is that the experience of trauma, or more accurately, the effect of that experience, is passed somehow from one generation to the next through non-genomic, possibly epigenetic mechanisms affecting the DNA function and gene transcription. So parental experiences might alter the regulation of stress-related pathways early in development. This idea was plausible since the HPA axis is subject to early developmental programming. And furthermore, dysregulation of stress neurocircuitry is a fundamental feature of mood and anxiety disorders, including PTSD, and it's found to be prevalent in the offspring of these folks. And so I think in the last slide, we talked about how mood disorders in pregnancy can be associated with preterm birth, gestational diabetes, hypertension, low birth weight. Well, the way that they do this is by dysregulating the HPA axis. And so what they basically do is kind of create a hostile environment in utero for the baby. And so you'll find these babies coming early because they're like, I got to get out of here. Like the stress hormone in here is too high. You know, the progesterone levels are too low. I got to get out of here. So we have to kind of think about how our mental health and our past traumas play a role in what happens in our pregnancies. And so I think that that's just fascinating. Epigenetics is an emerging study, and it's kind of looking at how our trauma lives in our tissues. And I think it's really cool because we have the opportunity to then stop passing those traumatic experiences down and the post-traumatic state down. So in spiritual health, there was a study of 130 low-income urban mothers, and basically they just asked them, how does your faith affect your pregnancy? And 47% of them said that their faith had positive effects. 45% said, I don't think it had any effect, and then 5% said, I'm not sure. But for those people who said that their spirituality had a positive effect, they said that they felt more guided and supported. They felt protected, blessed, rewarded. They felt that they were in communication with God, that they had more strength and confidence, and that they had help with difficult moral choices. So they were navigating situations better, and that they just felt generalized positivity overall. And so I think that these findings point to the fact that a patient should be able to experience their spirituality in their medical care, and also, before, during, and after their pregnancy, because some people really find this valuable. And there's a lot of research out there about how faith actually comes into play when it comes to medical therapies, treatments, and even survival. So I am a big fan of bringing the patient's religion, and so I will ask them, what are some of your guiding principles? Do you practice a particular faith? Are you part of a faith community? So that we know kind of what those what their desires are in terms of navigating spiritual spaces, and what their faith is, because it's not really an opportunity for us to push our faith onto the patient, but it is an opportunity for us to make sure that their faith has space within the clinical setting. All right, so this is one of my favorite topics. We talk about the money, honey. So financial health, right? Some of the biggest reasons for all that cortisol, all that stress hormone is financial stressors, right? Who's ever had a money problem in here? Yeah, right? So you're like, whoo, I'm stressed out. So when you have an unintended pregnancy, that changes everything for you financially, right? And we could start to kind of have the conversation about what financial changes might need to be made, what financial stressors currently exist. Like if you got student loan payments like me, is this the best time for me to go ahead and try to get pregnant? So I have to think about those things. Do you feel financially prepared for a higher risk pregnancy? So I'll ask moms like, hey, in the event that we need to take you out of work 6 weeks before your due date for bed rest, what would that look like for you and your family? Like, how would we get through that? Do you have benefits at work that would cover an extended medical leave? Like, so we need to talk about those things with people, because people sometimes don't even think about it. This was a little graph that I pulled from Forbes that just talked about the cost of the pregnancy and delivery alone. And so most people end up with an out-of-pocket cost somewhere between, $2,500 and $3,200. So that's even a lot of money, right? So that's just for the pregnancy care and the birth and postpartum care. But then we got to raise the kid once it's here, right? So this is an estimate from USDA that came out in 2017. So we know we can jack this number up because we've all seen the inflation, right? So it's like, whoa, that's a lot of money. So it's quite a bit of money that goes into childcare and housing and making sure the kid has food and clothes and activities. And this is not even talking if you want to maybe send your kid to college. So we got to think about the financial aspects of this. And I think it's very timely to bring that up at the preconception visit so that families can start planning. Like Lois was not playing when she said, I'm going to send all 3 of my kids to college and nobody's going to have student loans. Now, my dad became a dentist, so he was in school for 8 years. So he kind of messed up the rotation a little bit. But the youngest daughter ended up with 1 student loan that's been paid off for like 30 years. So, we have to think about what we're doing financially too. This is a big deal, and it can be the source of huge stressors. I had a patient when I was working in Thomaston who needed to go out on bed rest for a long time, probably about 8 weeks, and be hospitalized. And so there really wasn't much that she could do about that. But she was a single mom and she had other kids at home, and it was really a tough time. And so we really had to pull together a lot of resources to make sure her kids had groceries and that she had people to help her with her child care. So it was really difficult. And so finances can be a tricky thing to navigate. Now, please don't misunderstand me to say that if you don't have $233,000, you should not have a baby. That's not what I'm saying. What I'm saying is, think about what resources you have, what resources you think you'll need, and start to plan for those things. So relational and social support are absolutely critical. And so the Moss study looked at women who were unpartnered, who reported more mental, emotional, and financial challenges. And so those women reported that. Now, here was the interesting part about the Moss study that I was really to me, it was just like hot tea. I was like, oh, they found out that pregnant people who had a partner who was unaffectionate actually did worse than people who were single. So when you have someone there and you expect that they're going to be there for you and support you and they don't do it, those women actually had higher risk of depression, anxiety. They had higher Edinburgh postnatal depression scores. So very, very interesting. And it was published in the Australian Journal of Psychiatry. And so there were a lot of women studied. And so it's so interesting that the folks who were partnered with an unsupportive partner, an unaffectionate partner, actually did worse. So I guess if you were single, maybe you expected to be single, maybe a little tougher. But if you just had the wrong partner, it was even worse. So that relational support is super important, and social support as well. You need a girl gang. I always say that. But I mean, not that men and partners can't be very involved in pregnancy and in birth and postpartum period, but you do need those people who've done it before, right? Who can sometimes be a voice for you and who can advocate for you. And so I talk to my patients about their relationships. Like, is your relationship a safe space for you and your baby? Is your partner someone you want to parent with, right? Some of us probably would make different decisions if we had it to do over again. And then, do you and your partner share common values when it comes to parenting and family? These are things that can be really important. And then, what's your support network like? Do you have a local village who can support you during pregnancy, birth, and postpartum? I had a patient when I was in residency who was from Cleveland, Ohio. And she had a lot of medical problems. So we were managing her, and she ended up needing to be delivered. And she had had previous C-sections, so we did a repeat C-section, and it was kind of a surprise. So she had a whole busload of people who were coming for her birth, but because she ended up delivering early, she was alone. And so that support network, I always stress the part of local, because you need people who can be there with you, who can be a warm touch, who can be a voice in the room and advocate for you. So we talk about that. And so, having someone that you trust that can be your advocate is very important. I'm not a big fan of pregnant people having to advocate for themselves. I feel like they're just trying to get through, right? They're trying to get through the pregnancy. They're trying to get through the birth. They're trying to get through the first 6 months of parenting and having a newborn. So I think it's very important that they have supports and protections around them so that we're helping them do this as a community. And then, of course, do you know an OB care team or office where you feel that you can get high quality, respectful care? So these are things that we need to talk about. And all of these things that I've gone over with you guys today really don't necessarily require someone who has a 4-year OBGYN residency training. These can be nurses who are talking about preconception health. This could be birth educators who are talking about preconception health. Doulas. We could have community workers who are just doing community health. Like, there are so many people who can help guide people towards developing a reproductive life plan and getting the checkups that they need to make sure that they're physically healthy, mentally healthy, and emotionally healthy prior to. And so when we fail to plan, we often plan to fail. And many birthing folks are at risk for adverse maternal and fetal outcomes simply because they just kind of forgot to plan. So I always tell my patients in my office, and they can probably repeat this to you if you met a few out in the streets. They say, Dr. Baker says, if you're not preventing pregnancy, you're planning for it. There is no middle ground. So we have a whole plethora of ways to prevent pregnancy, and so we need to avail ourselves of those options if we are not ready to get pregnant. And so I talk to them about that. And that doesn't necessarily mean medication. We need to do what Lois did. Lois didn't have any pills, patches, rings, injections, or IUDs. She learned how to track her ovulation, and she did it that way. So you could use a natural method of contraception, but we have to start thinking about what we're doing. Of course, uncontrolled medical problems can be a problem, lack of support. And then, when we have all of these things combined, it's a perfect storm for a high-risk pregnancy and a traumatic birth experience, which then kind of starts that cycle all over again, because a traumatic birth experience affects folks physically, emotionally, mentally. It can affect them socially. They may feel isolated. It can affect them financially. They may not go back to work in 6 weeks. It might be 12 weeks or even 18 weeks. So we have to think about how that whole system works. And then making sure that we are treating pre-existing conditions prior to pregnancy can be really helpful in improving outcomes. And so preconception health might have sounded like a really boring topic, right, before we finished. But it's actually an opportunity to create a safer, healthier, happier space for mom and for baby. So these are my references. And you can connect with me if you want to scan the QR code or visit my website. I'm so grateful for your attention, and I would love to hear your questions and comments and insights, because I don't just come to these places to talk to you. I want you to talk to me. So we can certainly entertain questions. Oh, all the way in the back corner.
I first just want to start off and say that you are very thorough. I thought that I had an amazing care team, but they are amazing, but you are very thorough. When you were talking, you said you do special considerations during the lab studies.
Mm-hmm.
How do you feel about B&P testing, given that cardiovascular diseases contributes to a large amount of the maternal deaths? I know that providers, they do the glucose tests to check for diabetes and other things, but it's crazy to me that no one does a B&P to check for cardiovascular health.
Well, so the B&P, the real money from the B&P is when you have someone who has preeclampsia, someone who you suspect may be in heart failure, so like someone with, who's having like massive lower extremity edema, shortness of breath, chest pain. So I don't know that I would get a B&P during the preconception period, but certainly if that person had a history of heart disease, that's a great marker to see where they are. Like if they had congestive heart failure or if they had a history of peripartum cardiomyopathy, I get a BNP just to see if they were in an exacerbation phase or if they were like normal. Because the BNP is going to look normal unless you have an actual cardiac event. And so I actually do use the BNP as part of my preeclampsia workup because that can tell you who might be at risk for developing. So see, most of the heart failure that we see in pregnancy and postpartum is due to preeclampsia, actually. So when we see preeclampsia, I'm always looking at that BNP to see, like, is this someone I really need to be watching to avoid heart failure in? So I think that's a great question. If you get a cardiac workup, usually that's going to include a EKG and an echocardiogram. I do think that if we refer someone to cardiology, an echocardiogram is always warranted. And if your echocardiogram is abnormal, so the echocardiogram is an ultrasound of the heart, and if you show abnormal heart function, then a BNP certainly is indicated so that you can see, hey, is this a normally functioning heart? So I think you could certainly use it, but it might not be the most appropriate test for like your preconception screening unless you have heart disease or heart disease risk factors and you're referring to cardiology.
Sorry.
Mm-hmm.
I love that you had a conversation. She felt comfortable talking to you about that she was struggling. I know that most providers do like some kind of mental health screening, some type of form or something, but you actually talk to her, and I feel like providers should make time for their patients. You mentioned earlier you give 30 minutes. A lot of providers don't do that. They just get you in and out, ask you a few questions, and then, that's it. So I just wanted to thank you for that part.
Well, I so appreciate that. I will say that is not something that I always had time to do. One of the things that we have to realize about our system, our healthcare system, when it comes to maternal health, is that the majority of your OBGYNs and midwives are working for large health systems. And it is dictated a lot of the time how many people they have to see in a day, how much time they get for an appointment to see a person, how much time they get to document on that patient. And there's a lot that you really need to be getting done during these visits. It took a lot as a matter of fact, what I had to do to be able to have the time that I want with my patients was to put in my contract. To say, like, this is the number of people that I'm going to see in a day. This is how this is going to go. Like, so it really literally, my contract attorney is amazing, but we literally had to write this out, and then I get half a day to catch up on administrative work. So while I do agree with you, we should take the time to actually talk to people. We do use a validated form screening tool, but we also have to ask the question because some of our validated tools are not very adept in finding these issues, particularly in African American folks. And so we also have to sit down face to face and connect with the individual. But while I do agree we need the time, we also have to have systems that allow us that opportunity too. Any other questions?
Hi. I wanted to go back to when you were discussing the campus. And we know about the direct smoke from our expectant parents. So as a PA who's actively involved in delivery, as well as a childbirth educator now, what about our expectant families and our mothers who are not smokers, but they're exposed to cannabis? Now, I am seasoned, and it smells a lot different than it did
Yes.
when the Rick James and the Funky. And as our previous presenter, they will tell you, oh, it's okay, it's okay. So if you get out early as I can, I get out sometime at 5:30, 6 o'clock to go to work, and you smell it.
Yeah, everywhere.
So, but if you have a patient come in, and she will go to great effort to say, but I don't smoke, but she smells, and it's stronger than ever in 2023.
Yes, I totally understand where you're coming from. I mean, literally, you could be driving down the street and just smell it in the air. Like, I'm like, oh, okay. So when I'm going in early in the morning for surgery, I often just ride down the street and it's like, oh, okay, I think I got a contact. So, but certainly, cannabis is 500 times more potent now than it was back in the days when y'all were dancing to P-Funk. So we have to be mindful of that, and we have to really educate our patients and our families about that too. And so folks may say that they're not smoking, and they may not be. I think it's that there are definitely lots of ways that you can end up smelling like that, but we have to also talk about secondhand smoke. And so I'm very candid with my families. If it is the partner or the dad that's smoking, I tell him, hey, exposure to these residues on your hands and your clothes can really put your baby at risk. So if I come in a room in the hospital and baby's out and dad smells like he just smoked a whole pound, I have him put on a scrub top, wash his hands up to his elbows before he picks up his baby. We have to be better about educating folks. And once mom sees that, she's going to make him do that every time. She's like, don't touch my baby until you wash your hands and change your shirt. Yes, thank you for that question.
Good afternoon. My name is Alicia Cutting, and I am Rural Health Equity Director for Savika Rising, located in Albany, Georgia. But I do a lot of work with Black Lives Matter as well as Morehouse School of Medicine. My question is really, can you please shed some light, based on your statistics, based on the statistics about U.S. births as well as in the South, in Georgia, but particularly in rural health areas, where we're seeing hospital closures, we're seeing higher rates of all kind of comorbidities and all kind of other catastrophic, in my mind, settings that are really creating an atmosphere that is so detrimental, in addition to all of the other issues that are affecting Southwest Georgia. Can you just speak to that and things that you might suggest that nonprofits like myself or other people who are working in these areas that are able to really make more of an impact? However you want to answer that question.
Okay, so let me see. I think I kind of got the gist of what we're talking about. And I think, what it boils down to is the simple question, like, why do we have these huge disparities in maternal mortality? And the answer is systemic and institutionalized racism. Period and full stop. So we have to think about the fact that there is this condition that exists called weathering, and it is where, people are not only dealing with the normal physical things, but they're also dealing with a lot of the psychological things that happen in environments where racism has existed for years. We talked about epigenetics and how trauma gets passed down in our tissue. And there have been some very egregious, traumatic experiences that have occurred in Black women. And I was at a talk in, where was I? Florida last week, and we were talking about this weathering condition, and we were talking about how this really affects not just Black women who are in rural areas or who have a low education level or who have low socioeconomic status. In fact, there are studies dating back to the 1990s that a Black woman with an advanced degree is more likely to die than a white woman who has not achieved a high school diploma. So even if you have done everything your mama told you to do, go to school, get a good job, wait till you find the right man, get married, have your kids, you are still at higher risk, even though you might have the best health insurance and access to the best birthing centers. You're still at higher risk of dying. And so we have to think about, well, what's underlying that cause? And weathering is where we have physical effects of the environment in which we live. And so when you're hit daily with micro and macro aggressions, it actually ages you. So even though I might only be, say 21, inside my blood vessels, there might be a whole nother story. They may look as if I'm 50. And so blood vessels and vasculature and the cardiovascular system is majorly important in pregnancy. It is majorly important because we're growing a human. And the placenta is a big network of blood vessels, and that placenta supplies the oxygen and nutrients to that new developing life. So if you have problems with underlying vascular disease already, that's going to be a big problem. And so I think that we're seeing, and mainly hypertensive disorders and heart disease is what's taking out Black women. cardiovascular disease and problems. And so a lot of that can be attributed to a lot of the things that have happened with systemic racism. Like we talked about, you hear people talk about redlining, where people are kind of relegated to one particular area in their community. That area may not have the highest property taxes, so maybe they're not good schools in that community, and they're not hospitals in that community, and they're not the other businesses that make communities sustainable and thriving. So we have to kind of start to think about that whole system, how the ecosystem is set up, and start to dismantle it at those layers. But in the immediate time that we're facing now, because there is definitely a sense of urgency to move on these issues, is we have to wrap as many supports around our patients as possible, and to realize that a rising tide lifts all boats, right? So it's not just necessarily about Black mamas, but centering Black mamas is what's going to get us out of the bottom rung in terms of maternal morbidity and mortality in the state of Georgia. And so that's a hill I'll die on. I think it's very important that we are looking at this problem practically. And if 30% of all maternal deaths across the United States are Black women, and we're not even 10% of the population, we have a problem. And I think we all have to be able to look at ourselves in the mirror to admit that, and be able to say, okay, well, now how do we dismantle some of these systems? But in the meantime, as much education, especially preconception education, we could do, as much support as we can give during the pregnancy, the birth, and the postpartum period. Those are things that are going to help us for the immediate, but for the long run, how do we dismantle some of these systems that have historically kept some people at a disadvantage? Thank you for that question. You knew I wanted to talk about that. Anybody? I think we have 2 questions over here.
Good afternoon, Dr. Baker. My name is David Battle. Just a quick question. I'm an uncle of a newborn now and a 2-year-old, and I'm just reflecting on, you said, the social network. They're currently in Michigan, here I am in Georgia. How can I best improve in regards to just being more active, providing a social network and just supporting the mother, and just overall just releasing that pressure? Because from just this presentation alone, I'm just learning that from the female perspective, there's a lot that y'all go through in regards to childbirth. So how can I help on my end, even though some things I just can't see in regards to the mental stress when it comes to childbirth?
I think that's such a wonderful question. I really love when supporters try to get involved and see what they can do. And if you live remotely, one of the things is just really checking in and saying, hey, how are you doing? How are the kids doing? How's everything going? Can I Instacart you some groceries today? Or can I send dinner today? Was it a tough day? Can I DoorDash you some dinner? There are lots of things that we can do to kind of alleviate stress, because sometimes it's not always about fixing the problem. Sometimes it is about just hearing the person and understanding what they're going through and giving them some words of encouragement. So even though you may be remote and you can't get there every weekend or every month, it can really help just to say, hey, I know that you're probably going through a lot with a newborn and a 2-year-old. Is there anything I can do? How can I help you? Is there support that I can offer you? And I think that just knowing that there's somebody in her corner would be really valuable to her. Mm-hmm. Thank you. Yes, ma'am. Oh.
Hi. I wanted to ask you, your patient population, across the board demographically, young, middle, all ages, does it span all ages you see in your practice?
Yeah.
I'm just wondering what's the reception to preconception counseling? Completely supported. I'm a health educator by profession, and I see that people glamorize not planning. Well, you know how to get pregnant. When you find yourself in this, obviously contraceptive failure accounts for 50% of failures, but when you meet with the women, what's their reception? Are they receptive, positively receptive to planning?
So my patient population does span the gamut. My youngest patient right now is 15 and my oldest is 48 in terms of like for my pregnant patients. And what I do find is that my more seasoned, experienced women are more likely to come in for preconception counseling. What I also find is that my, school age or adolescent pregnant patients, they know that you can get pregnant having sex, but they have no idea how it works. And that's one of the things that we really have to spend a lot of time on is education, just about your body and how, ovulation occurs and how fertilization and conception occur. And so I think that even across the age groups, there is a lot of misconception and a lot of, people just don't know. Their mother didn't know. They didn't really learn it in school. And so we had worked at one point in our county when I was in Upson about 3-4 years ago into looking at some comprehensive sexual education courses for schools. And we did a lot of work on that and found some really great curriculums, but I think it was just, folks felt really uncomfortable with it and they weren't able to implement. And so I think we have to first put that education out there. But when I meet with folks in my office, they're very receptive to this because the conversation that I have, and I don't know how you guys talk to your clients or patients, but I talk real with mine. I'm like, hey, we want you to get pregnant, have a healthy pregnancy, a safe delivery, and be around and be healthy enough to raise and interact with your baby. So that whole purpose of this preconception visit is for us to be able to do that, to identify what risks you have and how we can eliminate or at least optimize those risks for you. So yeah, I think they're very receptive. Thank you.
One more question. Backstory. When I gave birth in 2020, I ended up in the ICU a few days later with a blood pressure of 246 over 130. How do you feel about the postpartum appointment being 6 weeks after a birthing person gives birth and not sooner?
So the postpartum appointment should not be at 6 weeks anymore. We should be implementing the 4th trimester guidelines that have been set forth by the American College of OBGYNs. And I recognize that we certainly have a lot of areas where OBGYN care is scarce. So we have to, account for that. But my patients are coming back at 2 to 3 weeks. And if you had any sort of hypertensive disorder, you're coming back in 3 to 5 days. So we have to really follow those patients very, very closely. Preeclampsia is a killer. And we all saw this last week when Olympian Tori Bowie died from eclampsia. But eclampsia should be super rare because we should be catching preeclampsia before it becomes like pre-eclampsia. We shouldn't have eclampsia because we should be paying attention when it's preeclampsia and treating it appropriately. So I don't do postpartum visits. We have a 2 to 3 week, a 6 week, and then we have a 3 month and a 6 month and a 9 month. So now that we have 12 months of expanded postpartum Medicaid, you can do that. And one thing that we're doing at that 3 month visit is establishing care with a primary care provider. So either a family practice doctor or an internal medicine doctor. If you have preeclampsia, you have to see a cardiologist within 2 weeks of going home from the hospital. So there are a lot of guidelines that are out there. Whether or not systems have the resources to implement those guidelines though, sometimes, it's the rate limiting step there. But no, I don't think anyone should be waiting 6 weeks anymore.
I'm going to take one more question and then we're going to break for lunch. It's so wonderful. I hate to do that, but I want to keep us a little bit on our schedule. And then I'll ask that you go out and fix your plates and then kind of bring them in here, and we may continue on because I want you to hear all the great stuff. We've got some great speakers for after lunch as well.
Dr. Baker, I heard you talk about, preconception and planning, and I come in contact with a lot of women, and one of my things I do And what I find out most of the time, it was unplanned. And, you know, I said, oh, where you get them? I said, what were you using? I said, look, guys, and they're laughing. I said, I got pregnant in 5 years, 6 years. So then I just go through the history like you, as far as telling them, I say, hey, you know, you get the wrong information. I'm not like culture now, because that's all I deal with for my pregnancies, that's my women. I said, we get the wrong information in high school, even in college, and then from my family. I said, so we have to get the right information. And I always ask them, because I like to trend and analyze, most of them, 90-some% are not using birth control ones that I ask, because, she got pregnant with an IUD, you gained weight. I said, she gained weight because she wasn't doing exercise anymore, walking exercise school. Most of mine are using because of these myths out there that no one has taken just a few minutes to correct them.
Yeah.
And then check with them when they're on the birth control. I call them 2 weeks or whatever, so if they have next time, the next plan or whatever. Because sometimes you gotta prepare them. The doctor tells me, I'll tell them what about the legal stuff. But we call and I say, okay, remember now, they tell you, let's wait a little longer. There should come some warning signs that you really need to call that doctor. So that, I'm finding that really helps a lot. For them to stay on the birth control afterwards when they do agree to try afterwards. It's not even simple.
Yeah, I absolutely do agree with that. At my, I have a YouTube channel called Delivering Joy MD, and I have a whole playlist on all forms of birth control, even natural birth control, like even just tracking your cycles and being able to do that. So we share that with all of our patients when they come in for their annual, like all our women of childbearing age. So if there is something different that they want to do, because I say that same thing I say all day long, is if you're not preventing pregnancy, you're planning it. So, and I love one of my friends gained weight on birth control, and I'm like, well, I guarantee you pregnancy will help you gain more weight. So we have to talk about that as well. And so I do agree with you that educating folks is super, super important, and letting them choose what they want and what they can stick with. Yeah.
The Center for Wellness for Black Women, they have a thing on Thursday once a month. They talk about it's free, you can send them questions, and honestly, a lot of people just don't know about it, and they can ask questions.
Oh, wow, that's awesome. That is awesome. Thank you so much. Yeah. There are lots of people who have all kinds of information out there, especially on the web, like that's reliable.
Thank you, Dr. Baker.
Thank you.